So therapeutic approaches to clinical psychology. If someone comes manifesting depression or anxiety or schizophrenia, like how does a therapist or a psychologist or a psychiatrist respond to that? What are the avenues? Now, y'all may remember that in the DSM-5, it doesn't specifically say, oh, the only treatment for this particular disorder is cognitive behavioral therapy or free association. It's basically left up to be open to interpretation, so it's not a one-size-fits-all kind of experience. Now, there are some things that you can do in your day-to-day life outside of therapy and medication that can help with mitigating the effects of mental illness. You have a creative outlet, maintaining your interest and channeling your energy towards something productive. Exercise can help with fighting against mental health issues. Having a routine, that's particularly important in day-to-day life just for neurotypical people, but also people who fall on the spectrum with Asperger's or autism. It's incredibly important to maintain a routine because that represents stability. If you know what's going to happen next, then you have less anxiety about the rest of the day. And I know y'all from personal experience, you can probably talk a lot about how a lack of a routine has disrupted this year. Think of all the different schedules that we've had and the shifting back from completely virtual to half and half back to completely virtual and all of this stuff going on, that it's just been like a huge thing to overcome in terms of like mental health or just day-to-day functioning. Sleep is also critically important for your mental health. Like we talked about with seasonal affective disorder, having too much melatonin in your brain and then you trying to fight that melatonin to stay up can make you irritable, cranky, and sad. Meditation, like what we do in Wellness Wednesday, taking time to just chill out and breathe. Social activity, interacting with other people can help with mitigating some of the effects of mental illness. A healthy diet, love, sun and air. So like if y'all have heard on Twitter, go touch grass. So go outside and breathe in the air, unless you have allergies, in which case you may want to stay inside. Humor. And then, of course, therapy. So all of these are routes that you can use to help mitigate the effects of mental illness. All right, so we're going to talk about a lot of psychologists in this unit. Think of these people as ID terms. These are key names that you need to be familiar with this unit. And some of them we've already discussed together, so it should just be a repeat of what we've already learned. So with Aaron Beck, he is best known for cognitive therapy. He's known as the father of cognitive therapy, kind of like Freud was considered the father of therapy in general, or the psychoanalytic approach. Now, y'all may remember that Freud's ideas weren't really scientifically based. They were very subjective, and he focused on sex and aggression and childhood trauma, and he kind of focused on women being naturally hysterical and things like that. So it was more so like he was just spitballing. Okay, he was just brainstorming therapy, and then some of it caught on with free association and whatnot. Aaron Beck is going to want to make this a little bit more objective. Okay, if you have a client coming in saying that they're depressed or that they're anxious, how can you measure that? It's not like you can collect their blood and then do a blood test and be like, oh yeah, your depression levels are at an all-time high. It's not like cholesterol, right? And so in order to address this, he tried to create an inventory or a survey that he could have clients take, and then it could give him a certain degree of certainty about whether or not they were depressed. And so this is still used today, the Beck Depression Inventory. Some doctors and just regular doctor offices will use it too to screen for new patients, or every time you do a yearly physical, you may have to fill out one of these inventories. I think they also do one for bipolar once you hit a certain age. And so this is just a survey that you can take indicating how you feel about certain things and what emotions you've been going through. And then it gives a numerical score to indicate your risk of depression. Same thing with the hopelessness scale and the suicidal ideation scale. Now, suicidal ideation is when you have desire to commit suicide. So a desire to harm yourself rather than, harming others. It's important to note that psychiatrists and therapists, counselors, even the guidance counselor, they're all mandatory reporters. So if at any point you express a desire to hurt yourself or others in therapy, that's where the client-therapist privilege ends. And then there's actual paperwork, there are actual forms that they have to go and then fill out to have someone come and check up on you. If someone expresses suicidal ideation and they seem like a threat to themselves or others, in some states, like in Florida, I know it's called the Baker's Act or Baker Act, you can have someone involuntarily kept in a mental facility for 72 hours while they're evaluated. And so if someone is threatening or claiming that they're going to commit suicide, you can call 911 and they'll send officers or mental health specialists, probably more likely officers because we don't really have a lot of mental health specialists around, and they could have them involuntarily institutionalized. This is something that like some students have shared with me, that they know of people like old partners or like their parents' relationships where someone would threaten suicide if like they broke up with them, like if you leave me, I'll kill myself, that sort of thing. Well, I mean, if you call for help and get resources for that person, that would be like the next best step rather than trying to put all of that weight on yourself. Like, oh, I have to do this, that, or the other, or this person is going to make this decision. So there are some people who do take advantage of the stigma against mental health and try to use it for emotional manipulation. But if you do feel like a friend or someone that you know, or even just a stranger, is expressing those feelings of suicidal ideation, then it's best to contact somebody with some level of expertise in it. So it should never just be taken as, oh, they're joking, or, oh, they don't really mean it. So it's better to be safe than it is to be sorry. So a therapist will give out these inventories in order to screen for these things. And as mandatory reporters, they do have to take action or they could be held legally liable for that. So that's also important if you're looking at going into school for a career in psychology, is knowing it's more than just talking to people about their feelings. There's actually like steps and legal responsibilities that you will have, which is why the schooling takes so long. Now, we talked about Carl Rogers before. He's responsible for humanistic approach to psychology. So y'all may remember another humanist psychologist was Abraham Maslow. What is Maslow famous for? That's hierarchy of needs, exactly right. And so Carl Rogers is within that same perspective. Now, he is going to try and focus less on the therapist role and more on the client's role within this type of therapy. This is supposed to be very client-centered therapy. You should do active listening to the client rather than just spitting out answers or solutions to what they're going through. And when you're centered on this client, you're supposed to also provide unconditional positive regard. So even if they share something embarrassing or problematic, don't try to judge them or to make them feel a certain kind of way about that experience, but instead witness them and let them have that space to discuss what was going on or what they were thinking. And then tie that back to their idea of their self-concept. Remember that you try to get congruence between your ideal self and your real self. How are your real self and your ideal self different from each other, and how do we minimize those differences? So if someone says something that you're like, well, that's not a good idea, instead of just saying, that's a terrible idea, say, how would your ideal self respond to that situation? And then how can you model that to bring that more into congruence rather than attacking like the person or the idea itself, and also letting them get to that conclusion by themselves. All of these terms were created by Carl Rogers, and this is still a very popular perspective, particularly since it allows for the idea of free will amongst humans. Now, which perspective did not believe that humans had free will? Y'all may remember John Watson and B.F. Skinner, tabula rasa, said if you give me 100 babies and I can create the conditions in which they're raised, I can make them into anything I want.
Isn't that like the behaviorist approach?
That is the behaviorist approach. Good. Humanistic approach came in direct conflict with the behaviorist approach, just like the cognitive approach came out in rejection of the behaviorist approach. They're saying there has to be more than just external quantifiable behaviors to make this a science. We also have to deal with cognition, and we also have to recognize that humans have free will. Now, y'all may remember us talking about the difference between psychiatrists and psychologists, the biggest difference being who can prescribe medication. The psychiatrists have medical degrees, and so they can prescribe medications. They can provide both therapy and medication. The psychologist, however, can only provide therapeutic approaches. They cannot write you any prescriptions, so they may have to pair up with your primary care doctor. If you go to a psychologist and they give you Beck's scale for depression, and then they see your results and they're like, okay, you need to go to your doctor, your primary doctor, and give them this and say, this is what we found, that you need to be started on Paxil or Zoloft or Prozac for the next 2 weeks or what have you. So a psychologist can do therapy and research, but not prescribe medications, which is why to be a psychologist, you usually only need a master's or a PhD. But if you're a psychiatrist, you definitely need the doctorate degree. So if you're looking at going into psychology as a career, keep in mind that you can't really do much with just a bachelor's. Like I have a bachelor's in psychology and I can teach. That's all I can do. I'm not qualified to give therapy. I'm not qualified to prescribe treatments or prognoses or anything like that because I've not been licensed. If I were to go on and get my master's in psychology and then a PhD in psychology, then I could do all of those things. So if you're going to go into psychology as a career field, you're going to need to go for your bachelor's, your master's, and your PhD, which could be anywhere from 6 to 12 years of school. So with psychotherapy is just therapy. So if you see that and you're like, oh, what's psychotherapy? Like it's just therapy. It's a catch-all term and it's designed to identify feelings and behaviors and thoughts and how those feelings, behaviors, and thoughts can impact your mental health. And there's going to be a myriad of different approaches for therapy, but you do have some that are used more often than others. The stereotypical view that you get of therapy is someone laying down on a couch and talking to a therapist. That's the psychoanalytic approach, the free association, just talking and talking and talking. Something from your subconscious or unconscious comes out and you can like take that manifest in latent content and make it mean something. That's what we think of when we like see therapy portrayed in cartoons or in commercials or things like that. But that's not the most popular form of therapy. You're very rarely going to go into a therapist's office and then like lie down on the couch and then just start talking about whatever. Most people can't just, sit down and talk. Like they have to have some guiding questions. And so that's not going to be the predominant form of therapy that we see. The most popular form is the cognitive approach. Although we do see that the cognitive behavioral approach, which combines both of those features together, is going to be overall the most popular. So really eclectic, taking different pieces of different approaches and putting them all together to best fit whichever particular client you are seeing at that time. So cognitive and behavioral often will combine into one. You don't have a lot of just behavioralists. That's kind of just not in vogue anymore. But then the second most popular one is the psychoanalytic and psychodynamic approach, which y'all may remember with Freud and Adler and Horney. All right, so cognitive therapy, the most dominant form of therapy. This was created by Aaron Beck. So y'all may remember we talked about him with the scale for depression, hopelessness, and suicidal ideation. And it focuses, not surprisingly, on how we think about things. So it's not focused on actions or behaviors. It's focused on the internal, the things that you can't see or quantify or measure objectively. And so basically the main focus of this is going to be how we define control and how we think we interact in the world around us. Because how we think we can or can't interact is going to have an effect on our attitude and it's going to have an effect on our behavior regarding our environment. So techniques involved in this therapy include modeling and role playing. So going through different situations and then changing the way that you think about those situations. So like if you have social anxiety, they may focus more in cognitive therapy on modeling how to have a conversation, the schema of having a conversation. Or they may focus on, okay, I'll role play the waiter and you role play yourself. And then we're going to have a whole conversation. Try to avoid when the waiter says, enjoy your meal. And then you say, you too. And then you're like, oh man, now I have to leave. I do that all the time. And I'm just like, now I have to buy them food. I'm sure they wouldn't mind. So an example of that, let's look at two different situations and how someone could respond cognitively to those situations. Let's say someone loses their job. It's like, will they look under the bed? No. So they lost their job, and so they have internal beliefs about why that happened. In the first example, the internal beliefs attack the self. They believe that they've lost this job because there's something wrong with them, that they are worthless or that it's hopeless and that they'll never be able to get a job again and they're going to die homeless in a ditch. That's going to lead to depression. So the same action occurred here with lost job, but the belief is what leads to the consequence of that. Your belief about why you lost your job or how it was just all your fault leads to the manifestation of a disorder. In contrast, let's say we have a more positive view or an external locus of control. I lost my job because my boss is a jerk and I deserve something better. If you have that mindset, that cognitive beliefs, then you're not likely to develop depression. Again, the main focus here is that it's on beliefs. This is cognition. What's going on in your head in terms of appraising your environment? How do you appraise what's going on? Is it your fault, someone else's fault? Is it internal problems, external problems? And then that can result in how you respond in terms of behavior. Albert Ellis is also a famous psychologist in cognitive psychology. We've talked about him before with rational emotive care. Y'all may remember us talking about the ABCs. So action, belief, consequence. In this particular definition for it, they address A as adversity. So let's look at adverse experiences. Breakups, never fun. Failing a test, never fun. So this is defined as adversity. But your different beliefs can lead in different consequences to those adversities. So let's look at breakup first. But you believe I can do better. That's why I dumped them. That's going to lead to a positive attitude. You may be able to go out and meet people or give your number out to somebody because you're not hung up on that old relationship. Even if you were the one broken up with, you're like, nah, I can do better. It just wasn't meant to be. Positive can-do attitude. Versus if you have a breakup and you fear that you'll never find somebody. You're like, oh, I'm innately unlovable, or there's something wrong with me that they wanted to leave. That's going to manifest as a disorder like depression or anxiety. Let's say you fail a test. I should have studied harder. That's your belief. Your belief is that you could have done something to do better. You are capable of doing better. That is a positive attitude. Versus fail a test, I'm stupid. That's the only explanation. It's not that I lost my book or I had to work the night before. It's just that I am inherently incapable of doing well in school. That, again, would lead to depression. Okay, so your beliefs about something or an event can have a huge effect on how you respond to those events, emotionally and mentally. Now let's move over to behaviorism. Behaviorism differs because it is not focusing so much on thoughts. It is focusing on conditioning. How do we learn something? And if we've learned something that is now maladaptive, how do we change what we have learned in terms of behavior? Y'all may remember that there's two different types of conditioning. There's classical conditioning, which is involuntary behavior. And what are some involuntary behaviors that could be classically conditioned? Fear, exactly. You could have fear. You could have salivation, like with the dogs in Pavlov's experience. You could have taste aversion. All of that can be classical conditioning. It is involuntary versus operant conditioning, which is voluntary, and it's based on punishments and rewards. Which one's more effective at changing behavior, punishments or reinforcement? Reinforcement, yeah, it's more effective to use rewards than it is to use punishments in order to reinforce a behavior. So the different techniques within behavioral therapy. In terms of classical conditioning, remember that the key to this is that they are trying to change involuntary behavior. So it's not like you can just tell somebody, don't be sad, or don't be addicted, or don't be scared. Like if it were that simple, then therapists would be making a lot more money. It's just like one and done. So you have to condition them to get rid of those involuntary responses. Aversive conditioning can be very effective in terms of treating addiction. Y'all may remember that earlier in the year, we talked about a medication used to treat alcohol addiction called Antabuse. And with that medication, if you take it every day, and you imbibe alcohol while taking that medication, you end up getting violently sick. Like not enough to kill you, but you're going to be throwing up. You're going to feel bad. You're going to associate that sick feeling with the drinking of alcohol. Okay, so that's aversive conditioning, trying to train you instead of having that addiction where you're like, oh, this is something that feels good and that I like to do, instead recreating it as something unpleasant. All right, systematic desensitization is a slow form of following an anxiety hierarchy. So it's systemic because you do it over time. Let's say that someone has a phobia of feathers, and I mean like a real phobia, like they can't be in the same room as one. Well, you would start creating an anxiety hierarchy and ask them, what's the scariest thing that could happen to you with a feather? What's the least anxiety-provoking thing that could happen with a feather? So you may start at the bottom where you're in the room with this client and you have a feather in an envelope, and you've written the word feather across the envelope so they know that there's a feather in it, and they're freaking out. But then 20 minutes later, they've calmed down. Then you go to the next step of the anxiety hierarchy. You take the feather out of the envelope. You don't move. You don't walk to her or throw it at her. You just take it out of the envelope. She freaks out. 20 minutes later, calm down. Now you take a step closer to her until eventually you reach the highest point, which is them holding the feather, okay, the object of their fear. So desensitizing them to that emotional response to the thing that is causing them anxiety. This can also be used for testing anxiety. Someone with testing anxiety, you may have them sit in the classroom with nothing on their desk until they've calmed down. Then you put a pencil on their desk and then they calm down. Then you put a piece of paper on the desk until eventually you get to putting the test on their desk, and then they can take it without the anxiety blocking everything in their brain. Now, flooding or exposure therapy is when you do it a lot more quickly. Systemic desensitization, it's like, oh, in 20-minute intervals or until the person calms down. With flooding, it's just straight up, we're going to expose you to whatever is causing you fear. And when nothing bad happens to you, fingers crossed, hopefully, then you will not be afraid of what's going on. Okay, so like if you're afraid of snakes, go to a PetSmart and you hold the biggest snake. Or if you're afraid of rats, same thing, go to PetSmart and just stick your hand in the cage. Like I hate tarantulas. I've held one before, but like everything on me started sweating. Like I think even my earlobe started sweating. I was so scared, but I didn't like it, but I also didn't die. So I was like, okay, I think I can live with seeing a spider in the corner. I'll let him stay over there and pay rent by eating the flies. And then I'll just stay over here in my corner. Counter conditioning is changing how we perceive the stimulus itself. So like, let's say you have a fear response to math. What caused you to learn that behavior? What about math scares you so bad? I was scared of math before I ever made it to high school. I was like, in middle school, I was just like, yeah, this isn't going to do it for me. So I'm just going to go ahead and put this in the can't do pile. As soon as they started adding letters and they're like, what's the area of this shape? I'm like, I don't know. Like, so yeah, that idea, that cognition of why are you so afraid of this particular subject or this particular test or this particular person? And then changing how you perceive your perception of that stimulus. So it could be, well, maybe you didn't like history because it just wasn't interesting freshman year. Like you didn't have a good teacher. And then sophomore year, you get Mr. Baker and he's hilarious. And so you're like, maybe history isn't so bad. Or you feel like you don't understand history, but then you start following a history channel on TikTok. And you're like, oh yeah, 1-minute lessons. That's how I can do this. So changing your perception of, I can't do math. I'm going to fail. And then changing that to, well, actually, I have some behaviors that I could do in order to increase my ability, like practice or quizzes or online math games, those sorts of things. Virtual reality exposure. This is when you can't do flooding without some risk to the individual. Like say, for instance, a soldier has PTSD and they got it from an IED exploding while they're on tour. Well, you can't just, set off a bunch of IEDs around this soldier and be like, okay, here, you're flooding, desensitized. It's like, no, that's not how we do things. You can't just like blow up bombs and be like, okay, you're cured. And so instead of like fireworks or bombs or anything like that, you would just have virtual reality. You'd walk them through the situation, tell them they were safe, that they can calm down, do breathing exercises until eventually they're desensitized to it. So not exposing them to it in real life because, real life is dangerous. So operant conditioning is when it's voluntary behavior. Remember, fear is involuntary. You can't control that. It just happens. But let's say jumping up and down in class, that's a behavior that you choose to do. And so in order to modify that behavior under operant conditioning, it's more effective to use rewards than it is to use punishments. So a token economy is when you're given an award for certain behaviors that are supposed to be reinforced. Alcoholics Anonymous uses a token economy. What do I mean by that? Yeah, you get literal tokens. It's AA. You get tokens or coins indicating how many months or years or steps that you've completed in the program. And it's a physical reminder to you to your commitment to staying sober and being in recovery. Okay, so it's very effective. Behavior contracting. This is when you create a timeline with rewards. And if the person meets that timeline, then they get that reward. Okay, so like if your parents ever told you, if you make all A's by spring break or by the end of the quarter, whatever timeline it is, then I will give you $100. Okay, well, you know your timeline, you know the behaviors. Some of y'all are like, not worth it. You know your behaviors. You just have to meet that timeline in order to get the reward. Same thing happens in classes. Like if I say, if all of you turn in your homework by tonight, then next week, no homework. Or if all of you bring 5 canned goods then I'll give you a free homework pass. Setting behaviors, but you have to do it on a certain timeline. Now, if you combine the cognitive approach and the behavioral approach, that's where you get cognitive behavioral therapy. You're probably most likely going to see this abbreviated as CBT. So with this, it's not just behavior, it's not just emotions and thoughts, it's all of them combined. So you're trying to change maladaptive behavior by also changing your maladaptive beliefs. Now, it's going to be more effective to change a behavior first if you want to change an attitude. And that's because we go through a bit of cognitive dissonance when it comes to our beliefs versus our behaviors. So like here's an example of cognitive dissonance that maybe some of us can relate to. Your attitude is, I like eating hot dogs. So your behavior is, I often eat hot dogs, even though you know logically that hot dogs are unhealthy. So you know that hot dogs are unhealthy. How do you change your behavior with this? So it says here that changing a behavior is a strong first step to changing an attitude. Well, you like eating hot dogs, so you want to keep doing what you like. But first you change your behavior. You stop eating as many hot dogs. Maybe you branch out to hamburgers, or a pickle on a stick, something else, or maybe even Brussels sprouts, who knows. You branch out to other foods and you realize, I like stuff that's not hot dogs. And so you start eating other things. And so you get out of that cognitive dissonance. This is kind of like when kids only want to eat things that are like dinosaur shaped. It's like their chicken nuggets have to be in the shape of a dinosaur, and that's all they'll eat, or macaroni and cheese. Like kids can be really picky eaters. And it's like, well, you don't know if you'll like another food until you try it. So change your behavior, and then that can change your attitude. So with CBT, your emotions affect your behaviors and your cognition. Your cognition affects your behaviors and your emotions, and your behavior affects your cognition and your emotions. So they're all affecting each other at the same time. You have to combine them together in order to address the manifestation of a disorder. Thus, we must address all three aspects of that if we're going to make a change. Now we're moving on to psychoanalytic therapy. Y'all may remember Freud. He had some pretty crazy ideas. He was like, everything is about sex and aggression, and you have repressed childhood trauma that dates back to the stages that you went through childhood. What else do you think? He thought that women were hysterical and had penis envy. And so then we have the psychoanalytic theory that comes out and kind of moves away from the more extreme views of Freud. Like they still keep some things like his therapeutic approach and some of his definitions, but they move away from like especially the gendered stuff when it comes to the psychoanalytic theory. In particular, Karen Horney is going to say that no, women don't actually have penis envy itself. Instead, they envy the political and social power that men have by virtue of their gender, not necessarily by virtue of their physical parts. She's also going to term the phrase womb envy, where men have an envy of women's ability to create. Okay, so kind of turning that model around. With the psychoanalytic theory, you're going to see that stereotypical view of what therapy is, that free association. Remember, free association is just going in and talking about anything. There's no structure. There's no rubric. There's no questions that the therapist has ready on note cards. And he's like, okay, when you answer that, I'm going to move to the next one. It's just free diarrhea of the mouth, with the hopes that eventually you'll come across something from your subconscious or unconscious and bring that to light, and you'll be able to interpret it. Now, in order to do that, you need to be able to differentiate between the manifest and the latent content. Now, does anyone remember what those terms mean? It goes back to our unit on dreams. You're thinking about manifestation, so like self-fulfilling prophecy. Yes, baby? Exactly right. How many of you have ever had a dream and it makes no sense? You're just like, I was running in a jungle and I tripped over a snake and all of my teeth fell out. And it's just like, that's the manifest content. That's the storyline. Okay, that's the plot. The latent content is the hidden meaning behind that dream. So like you're running through a jungle. Maybe there's not really much of an interpretation for that. It's unfamiliar. You're afraid of the unfamiliar. You trip over a snake. Well, Freud would say that that has something to do with genitalia. So it's like maybe you're uncertain about a relationship that you're having with somebody, and then all of your teeth fall out. Well, that's very clearly, in just general dream interpretation, that's very clearly a sign of anxiety and a lack of control. So you would interpret the manifest content of that as, the actual plot line. I was running through a forest, I tripped and fell, and my teeth fell out. Nothing special. But then if you look deeper into what could that represent? What could that mean? That's the latent content. That's the idea of, I have anxieties over my relationship and I'm afraid of losing them. So your subconscious is pushing that out while you're unconscious. According to psychoanalytic theory, yes. It depends on which dream theory you ascribe to. If you ascribe to activation synthesis dream theory, then dreams mean nothing. It's just random neurons firing. If you ascribe to information processing theory, it's stuff that you've went through during the day are being processed into long-term memory. So you're more likely to dream about something that happened that day versus the psychoanalytic theory of manifest and latent content. It means something. I mean, you can see this in popular media and even in religions as well. Like dream interpretation is a big part of religions. Like I believe, which Christian or Jewish king, was it David? No, it was a pharaoh. He dreamed of 7 cattle that were fat and then 7 cattle that were lean. And it represented 7 years of abundance and then 7 years of famine. And so they interpreted that dream to be a prophecy. That's where we get the idea of prophecies from. So now we're going to move on to the humanistic perspective. Y'all may remember Abraham Maslow. What was he known for? Good, the hierarchy of needs, which has some flaws. It's missing Wi-Fi and cats, but I mean, it'll work in a pinch. But also Carl Rogers is a big name when it comes to the humanistic approach. Remember that with humanism, you focus on the client. Humans have free will. They have autonomy, and that you need to treat them with unconditional positive regard, and try to get them to utilize their free will in order to increase congruence between their ideal self and their real self without being judgmental about it. So it's non-directive. It's more so you're an active listener as a therapist instead of just providing solutions. One of the things that I've learned as I've gotten older is that sometimes people come to you for help. Like they tell you about their problems for solutions to brainstorm, and sometimes they tell you to listen. So like if someone's coming up to you and you're like, okay, do you want me to listen for solutions or do you want me to listen just to witness, to hear what you're saying? Because that's a different kind of listening. So in this particular therapeutic approach, you're going to be an active listener, not so much asking questions or giving solutions, but just allowing them to come to that conclusion on their own, which as many of you know as students, if you hold a silence for a long enough time, somebody's going to talk. Somebody's going to say something. I do that all the time with my freshmen. And even if they don't know the answer, they're just like, I didn't hear the question. Can you repeat it? And I repeat it again. I mean, like with my freshmen, I'm just trying to see if they actually like are listening. With the biological approach, you can look at the biomedical approach with medications, but also there are some types of surgeries that can be utilized for certain disorders or divergencies. Like if you have a high rate of seizures, you could have cutting of your corpus callosum that could help. Electroconvulsive therapy or electric shock therapy is utilized for treatment-resistant depression. Obviously, that's not going to be the first step. Like if you go to your doctor and you're like, I think I'm depressed, they're not going to be like, all right, let me get out the car jumper. Like that's not going to be the first response. First, they're going to try therapy and medicine or a combination of the two. But if someone has treatment-resistant depression, then the medication and therapy is not showing enough progress. And so they'll rewire your neurons through electrodes. It's all external, it's not invasive, and it's not like, oh, you're going to be in like extreme pain. It's just like making those neurons pick up electrical signals because it's not getting the chemical signals that it needs to fire for those certain moods. It's not an ordained treatment for changing someone's sexual orientation. This can be helpful with depression or anxiety. It is not helpful with changing orientation. It has been used for that previously, but remember that homosexuality was dropped from the DSM in 1973 with the creation of the DSM-4, I believe it was. So they did drop that classification of sexual orientation as a disorder. You also have psychosurgery. That can include lobotomies. Like we saw that those were used a little bit in excess, during a certain period of time, particularly against women to try to control for what they considered hysteria or deviant behaviors. And so that's no longer an immediate response for mental illness. So you try to do stuff that's less invasive. But for some people, a partial lobotomy could be useful in treating certain disorders. But again, you don't want to do anything too drastic that's not reversible. You want to first try with the baby steps of therapy and medication before you move on to like electroshock therapy and actual surgery. The eclectic approach, that's a good picture, right? All right, so eclectic approach is when you combine different approaches because it's not all one size fits all. Some people may respond very well to the humanistic approach. Some people may respond better to cognitive and behavioral approaches together. There isn't just one set way that you can treat a disorder. So this is applying it to the client's preference and what seems to work best for that particular client. There are some people who may not want to take medications, and so it's focused more on therapy. There may be some people where therapy has not been effective enough, and so they'll refer them to a psychiatrist and try different medications. It's important to note that these medications that are used to treat disorders are not an immediate fix. It's not like, oh, I take a pill and then I no longer have depression. It usually takes a much, much longer time for it to work into your system. For family systems, these are other groupings within therapy. You have family therapy that can include like clinical psychology with a young child who shows symptoms of ADHD or autism. So working with the prognosis of that diagnosis, couples therapy, marriage therapy, child psychologists can include those who work in schools that do testing, not just for things like autism and ADHD, but also for gifted programs, and also sports psychologists. So like sports psychologists deal more with controlling anxiety. Like if you've ever played a sport and you've worried about choking when you're at the free throw line, or if you're about to be up batting or something along those lines, like trying to push out the crowd from your mind and focus only on what's in front of you, that's where that can be particularly helpful as well. Somatic therapies is just another word for medication. So psychopharmacology, it's a fancy word for saying medicine. You have different categories. You have antipsychotics. This can be useful for treating bipolar disorder or schizophrenia. People with untreated mania can result in delusions and psychosis. Anti-anxiety medication. This could be for personality disorders, including or involving anxiety, or it can involve OCD treatment or PTSD treatment. Antidepressants, obviously that can be relevant for bipolar disorder, personality disorders, or just regular old depression. And then the bipolar disorder in particular has its own class of medication. And we don't know exactly how lithium works to stabilize mood. We just know that it does. Like it's just all the preponderance of evidence. It's like, yeah, lithium helps control for bipolar disorder. We just don't know by what mechanism it's able to do that. So going through these different drugs for antipsychotics, it's important to know what these are used to treat. You don't have to memorize like the brand names of these particular medications unless you want to, or you may have already heard of some of them like Valium for anti-anxiety medication. But for the most part, the most important thing to focus on is the type of drug and what it's used to treat. So antipsychotics are going to be useful in schizophrenia because you can have delusions of grandeur or persecution that occur with schizophrenia, but also with treating the manic episodes of people with bipolar disorder, whether that's bipolar 1 or bipolar 2. Remember, bipolar doesn't mean, oh, 1 minute you're happy and another minute you're sad. It means you have extended periods of manic episodes and then extended periods of debilitating depressive episodes. The way that mood stabilizers work are that instead of being one extreme or the other, you're put in the middle. With antipsychotics, this doesn't help with depression, but it helps during the manic stage. So you may alternate between an antipsychotic while you're in the middle of a manic phase, and then when you move into your depressive stage, you move to depressants, all while still taking lithium at the same time. Now, some negative side effects that occur with antipsychotics is you can develop over time twitches and muscle movements outside of your control. That's called tardive dyskinesia, and this is just where like you'll have hand movements or facial movements that you can't control, almost like the development of a tic. You can also have some issues in terms of how much energy you have, an increase in negative symptoms, particularly with schizophrenia, which means like you lack affect or you lack appropriate affect or emotions, and then sexual dysfunction. Sexual dysfunction is going to be across the board with most of these medications, particularly depressants. It does have an effect on libido. All right, anti-anxiety medications. Y'all have heard of benzos. You've heard of Xanax, Ativan, Valium, Vistaril. All of those work to suppress your sympathetic nervous system, to get your parasympathetic nervous system, your rest and digest, to come into play. So it is going to increase the effects of GABA, which is already in your system, to help calm down that anxiety. Now, the issue with these particular medications is that they are very commonly abused. These benzos are often utilized in recreational ways rather than for their intended purpose. You do have high rates of physical and psychological addiction, and also, of course, the risk of overdose, especially when it's mixed with other depressants like alcohol. For mood stabilizers, this deals with bipolar disorder, because remember, with bipolar disorder, you're going back and forth between two different moods. Okay, so they try to stabilize in between the extreme depression and the extreme manic phase. We don't know how lithium works, we just know that it do. Remember that there are two types of bipolar. You have bipolar 1 and bipolar 2. One is more extreme than the other, okay, but they both involve mania and depression. So y'all may have heard of Adderall or Ritalin or amphetamines or methamphetamines. Those are all stimulants that can be used to treat ADD and ADHD. So attention deficit hyperactivity disorder or attention deficit disorder. So typically when we think of somebody with ADD or ADHD, we think of them as distracted and hyper and having too much energy. So why would we give them a stimulant? Why not give them something to calm them down? Well, it's a paradoxical effect. With the addition of the stimulant, it helps them focus that energy and focus that concentration on a particular task, as opposed to if you just gave them depressants and they just kind of got drowsy and they still wouldn't be able to focus their attention. So Ritalin, Adderall, phentermine, all of those are stimulants. It's kind of in the same class as methamphetamines, but they are different structurally. Like there's one extra compound in one or the other, but they perform in the same way where they act as a stimulant. Now, this is another prescription medication that is oftentimes abused, especially in high schools and colleges. Adderall is known as the study drug. So neurotypical people who aren't suffering from ADD or ADHD will sometimes purchase this medication illegally to take it to study for an exam or to get some project done because it leads to that hyper focus. But you can see issues with addiction with this particular prescription, both in the physical sense and in the psychological sense. And it can have an effect on your weight where it causes you to rapidly lose weight because with this stimulant, whether it's caffeine, nicotine, or amphetamines, puts a damper on your feeling of hunger. The next drug is antidepressants. There are technically 3 different types of antidepressants. The most common one that most people are familiar with is SSRIs, which are selective serotonin reuptake inhibitors. That's the one that most are familiar with. Y'all may have heard of like Prozac and Zoloft. What happens with these antidepressants is that you don't just take one and then immediately become happier. Okay, sometimes depression can be genetically based. The receptors in your synapses that are supposed to receive those neurotransmitters are few and far between. And so it takes them a lot longer to accept the same amount of serotonin as someone else's brain. So what this does is it'll block your cells from recycling that serotonin. Instead of the reuptake process beginning, it allows the serotonin to basically hang out in your synapses until your receptors are ready to receive them. Again, this will take 2 to 4 weeks for you to really see any change in mood. It's not going to be immediate. And you really should talk to your doctor if you plan on quitting an antidepressant because they will put you on a schedule to slowly decrease your dose. If you quit cold turkey, then you run the risk of going into serotonin withdrawal syndrome, which can heighten the effects of depression and lead to suicidal ideation. Basically, you'll feel like a wet paper towel and you won't want to eat or sleep, or you'll want to sleep all day and you just don't want to move. You just don't want to get out of bed. So it's important not to just completely cut off your brain from that medication. You have to slowly taper it down and then maybe you get put on a different medication. MAOI inhibitors basically stops these neurotransmitters from being burnt up by a protein in the brain. So it's rather than your brain getting rid of those neurotransmitters, it once again is allowing those neurotransmitters to hang out a little bit more in your brain to balance that chemical homeostasis. It's basically all the same things to me. I just know that I focus more on the SSRIs. Basically, it deals with specific neurotransmitters and how your brain receives them and how long it can receive them. Some of these, like Prozac, Zoloft, Paxil, these are like very common examples, brand names for antidepressants. You've probably seen some commercials for them over time, like on Hulu on cable. So like I said before, this helps to prevent the reuptake or the recycling of dopamine and serotonin that has been released by your vesicle sacs and the dendrites of your neuron and allows it to hang out in your brain a little longer. Some side effects of depression, particularly in y'all's age group, it does have a paradoxical effect where if teenagers start taking antidepressants, there has been evidence of an increase in suicidal ideation and an increase in depression. Okay, so typically they're going to be very careful about prescribing it to people under the age of 18, whereas like over the age of 20, there's not as high of a risk of it backfiring like that. Also, it can affect like your libido, like I said before, and it can also affect your sleep patterns and weight gain. The last slide that we're going to cover deals with a psychological figure who is the antithesis to psychology. This is a person who believes that psychology is all quackery, that it's all fake, that's not actually a science, it's not actually a medical field. So this is Thomas Sayce. So he wrote The Myth of Mental Illness, where he said that psychology and psychiatry is not a real science and it shouldn't be treated as such. So like one of his famous quotes is, if you talk to God, you're praying. If God talks to you, you have schizophrenia. So kind of like that cynical view as it relates to mental health. And this actually contributes, since this is fairly modern, this is going to contribute more to the social stigma where people say, oh, you're depressed, just be happy. Or, oh, you're anxious, just calm down. It's like, oh, well, now that you say that, why didn't I think of that in the first place? Now I'm cured. Now, obviously, there is plenty of evidence to counter this claim. Mental illness is made up or fake. So this is not the conventional view of psychology today. However, we still do see some aspects of that stigma persisting.